We're about to tell you about a very strange phenomenon that can happen unexpectedly in the operating room during surgery with devastating results. Under certain circumstances, a fire can break out, and even if the surgeon acts quickly, a patient can end up badly burned, even disfigured for life. The frightening thing is, Arnold Diaz found that it happens more often than you might think.
You may find it hard to believe, but nearly twice a week on average, something totally bizarre happens in a hospital operating room. Fire breaks out around and even on the patient. The fires usually occur during routine surgery and result from a rare mixture of elements commonly used in operating rooms. Emma Van Kirk, a home health aide from Pennsylvania, had gone in for cosmetic surgery on her eyes.
Thinking there was no real danger?
No. I would have never went if I thought there was danger, no.
During the operation, Emma was under local anesthesia, and although able to breathe on her own, she was being given pure oxygen through nose tubes like these. The surgeon was using an electronic scalpel which emits sparks. Only later did Emma learn what happened.
When he went to cauterize my eyelid, a spark flew. Of course, it hit the oxygen, and it blew up.
And what happened to you?
I caught on fire.
Literally caught on fire?
Yeah, I was on fire. I was burning.
Operating room fires are certainly not common. In fact, they are rare. Occasionally, they make headlines, usually when the fire kills a patient.
With 27 million surgeries performed a year in this country, an average of 100 operating room fires makes it statistically a very small risk. But when it happens, the results can be horrible. And the real tragedy, experts say, is that most of these fires are preventable if only doctors knew enough to take a few simple precautions.
It requires just the right things to come together at just the wrong time.
Expert Mark Bruley has investigated more than 100 surgical fires for ECRI, a medical research agency.
Here we are going to set up a simulation.
He showed 2020 what causes most surgical fires. It usually happens during head and neck surgery when there's a buildup of excess oxygen leaking from the patient's mask or nose tubes.
And it just lingers.
It lingers, yes. It stays there because we wind up covering the patient's head with the surgical drapes.
The problem comes when that oxygen is not adequately vented and gets trapped under the surgical drapes around the area being operated on.
We would be operating in this location here, taking a mole off or whatever. But the oxygen is now leaking up under here.
The surgical drapes and towels are flammable, as is the body hair. And sometimes all it takes to start a fire is a spark or heat. That can come from the electronic scalpels and lasers surgeons commonly use. Mark Bruley demonstrated.
Ready?
Ready. That quickly?
Yes.
Now this could...
All right, cut it.
This could be the patient.
Yes, that would be the patient.
This has happened. Patients have caught on fire.
Yes. Ready? The intensity of the fire and the spread of the fire is so incredibly rapid that after your initial startle reaction as the surgeon or the operating room nurse, by the time you reach in 3 seconds later to pull it off the patient, the fire is already very large and burning with an incredible temperature.
The result, as you see here, can be severe burns to the face, especially near the oxygen tubes or mask. It's exactly what happened to Emma Van Kirk. The fire shot up through the nose tubes, spreading onto her face and neck.
The only thing I can remember is trying to run.
Get off the table.
Get off the table.
Dr. Richard Greco was the surgeon operating on Emma.
And we pulled off the drapes and pulled off everything that was on her and poured water on her. We were very fortunate in this case to be able to extinguish the fire very quickly.
Nevertheless, Emma was left with deep third-degree burns. What should have been a routine operation has resulted in 6 years of painful reconstructive surgery.
They took a piece out of my ear, and this little piece right here, you can see right here, that's my ear.
Where you're not, it makes
Where
your
my nostril, yeah, they had, because there was nothing there.
Physically, Emma is recovering well, but the emotional scars have been much slower to heal.
How did this experience change your life?
Oh. It changed it really bad. I didn't want to cry.
Well, you've been through a lot.
I did really good until I had my first surgery.
A malpractice jury awarded Emma $600,000, but Dr. Greco says he provided appropriate care given her condition. He says he hadn't been taught about surgical fires, but has learned from the tragedy.
I mean, I was devastated. I couldn't understand why she was injured because I had done everything exactly the way that I was taught and the way I was teaching my residents to do the operation.
The medical schools do not address the issue of preventing surgical fires. It's not addressed in some of the major surgical texts.
For years, Bruley and a handful of other experts have been urging doctors to question whether pure oxygen is always necessary during head and neck surgery.
You're saying that you don't need pure oxygen in many of these operations.
In many of them, if not perhaps slightly more than half, you probably don't need pure oxygen. Room air itself, if it could be pumped into the patient, would do just fine.
Can you pump room air into them?
These days, many anesthesia machines can.
The benefit of room air in this demonstration at the Cooper Union Engineering School.
So we're placing a sample in the test box and we'll prepare it.
When a laser ignites a surgical towel with just room air present, which is 21% oxygen, the fire is very slow to spread. Now, watch what happens when there's concentrated oxygen around the towel.
So 3, 2, 1, fire. And you can see almost instantaneous spread of the flame.
So why do doctors use pure oxygen in operations where lower concentrations would suffice? It's habit more than necessity, says this expert anesthesiologist, Dr. John Bruner.
It's done almost gratuitously, it seems to me, without recognition of the potential hazard.
You're about to see a demonstration of another type of surgical fire that's even more rare, but also more dangerous and often deadly. It occurs not outside, but inside the body. It happened to Dennis Parker's son.
As difficult as it is to talk about this, we are very committed to try and avoid other people suffering like Doug did.
Doug Parker, a 22-year-old senior at the University of Texas, was having some benign growths removed from his vocal cords by laser surgery. A long plastic endotracheal tube like this was placed down his throat to pump concentrated oxygen into his lungs, along with general anesthesia.
The doctor would be operating on some of the throat area that's around this tube here?
Exactly. He'd be working in a very confined space, just fractions of an inch away from the tube.
And if that laser touches...
If the laser touches the tube, it will burn through the plastic and ignite the tube on the inside and send effectively a blowtorch-type flame down into the lungs.
Wow, that's shooting into the lungs.
That's into the lungs, yes. It's setting fire to the lungs from the inside out, and it's turning the trachea into charcoal.
It happens an average of 3 to 6 times a year, usually with tragic consequences. Doug Parker clung desperately to life for 91 days.
We never gave up hope until Super Bowl Sunday. And then his kidneys failed. The trauma from that fire was too much to overcome. And he died that night.
Dennis Parker, who settled a lawsuit with the doctor, now wonders why a flammable plastic tube was used instead of the laser-resistant type. Bruley says many doctors remain unaware of the risks of oxygen use and advises patients to ask questions.
Be an informed medical consumer by simply asking the anesthesiologist whether oxygen is going to be provided through a mask or with a nose cannula, nose tubes, and whether it's really necessary.
With only 100 surgical fires a year, 20 serious injuries, and 1 or 2 deaths, some may say it's too small a risk to worry about. Not Emma Van Kirk, not Doug Parker's parents.
Our question to each other and to the medical community is, why do mistakes have to keep being made here 4 years after our son's death, and they're still happening?